Our next speaker is Dr. Helen Partridge, who is a consultant in diabetes at the University Hospitals of Dorset and also a visiting fellow at Bournemouth University. She's got lots of clinical lead roles, but one of those is working on the Compassion Project and working with colleagues in the Eating Disorders Service to support people with type 1 diabetes. And that's what she's going to talk to you about today.
Thank you very much. I'm mic'd up all right. Perfect. Thank you very much. A slightly different talk here in that we were a pretty evidence-free zone when I first started doing this, which is nice because I don't have to come up with all the references and everything, but made it very difficult. In fact, when we first started doing this, there wasn't even a name for it, really. I mean, this is what was known as diabulimia, which I'm sure you've all heard of. It's not a very nice name. It doesn't really mean anything. And so, actually, we were in a tricky place when we first started of knowing what we were talking about. But we got some funding from NHS England to run a pilot study, a joint physical mental health project to look at this group of people. So that's what I'm going to talk about today. So I'm going to talk a little bit about eating disorders, an introduction to TIDE, which is what we now refer to this combination of conditions, how to identify principles of management, the outcomes of the pilot, and some resources, which actually when we first started doing this about 3-4 years ago, there were no resources. So I'm pleased to say at least we have something now. So what are eating disorders? It's a group of very serious psychiatric disorders. They have the highest mortality of any of the mental health conditions. They are disabling. You see anybody with a severe eating disorder, they've often got no friends, no family, they're not working. They're very dangerous and they cost a lot of money to manage. And we talk about the 3 Ps. So there's often a predisposition, so a genetic or a familial predisposition, or people are in sports arenas or ballet or things like that. The classic things that predispose to eating disorders. And then something precipitates it, something changes. So maybe going to university or an illness or a death in the family, something traumatic precipitates this change. And then this perpetuation, something keeps it going. So it may be, those comments you get, you lose a little bit of weight, and someone says, you look great, and think, right, I'll continue, I'll carry on with that. And it just perpetuates. But they're irrational. This isn't a choice. This isn't someone just going, I want to lose, I want to get into a size 14 instead of a 16 or whatever. This is not rational thought. When you try and analyse what people are living with, you cannot make sense of it. So don't try and work it out in your head what they're doing, because you can't. It's irrational. And we sometimes describe it as having this eating disorder brain. The easiest way I worked out how to understand it was to suggest that you actually have 2 brains in there. You've got your normal brain, and then you've got your eating disorder brain. And sometimes you can give it a name, so Derek or whatever you want to choose. But this eating disorder brain just grows and grows and grows, and it's pernicious. It's nasty. It knows all your secrets, and it can use them against you. Okay, and it wants bad things to happen. In essence, your eating disorder brain wants you to die. Wants you to starve yourself, wants you to vomit, wants you to do whatever it is. They're horrendous. Okay, and this thing grows and your normal brain shrinks. And the eating disorder brain is fed by starvation, by hunger, by ketones, by hyperglycemia, by dehydration. So the worse things get, the more this grows and the more this shrinks. And so it's impossible for the normal brain to take over and to fight this, and we've got to try and do that. And that's what we're dealing with. So type 1 and disordered eating, so the data that is out there suggests that 30% of people with type 1 diabetes report insulin omission for fear of weight gain, okay, and have disordered eating. I would argue that anyone with type 1 diabetes has disordered eating, because that's what we teach them, isn't it? We teach them to be obsessed with carbohydrate and looking at your food and can you do that, can you do that, I've got to do that, I've got to do that, I've got to think about that, I've got to think about that. I just have a sandwich. So it's really tricky. It's really, really tricky. And one of my colleagues, Nikki, who's in the audience, is one of my amazing nurses working on this area. She's got a favourite quote that says, if you teach someone to have type 1 diabetes well, you teach them to have an eating disorder. And I think it's absolutely true. And of course, because one of the commonest areas is insulin omission, there are different phenotypes, and we'll talk about that in a moment. there is this threefold increase in risk of death and reduced quality of life, and they develop the diabetes complications really early, because this goes on for years and years and years. And there was a horrendous study from the US that looked at 3 groups of people to look at the 12-year mortality in people living with these conditions. So with type 1, mortality 2.2 per 1,000 person years. If you've got anorexia, 7.3. If you've got type 1 diabetes and an eating disorder, 34.6. And that fits with data coming out of Edinburgh that says if you've got a recurrent DKA admissions, your mortality at follow-up for 6 years is around 30%. So those people that we get coming through the door all the time, their mortality, 1 in 3 mortality at 6 years. Okay, I don't need to go through this slide with you. You'll all understand this. You know, we teach people to have an eating disorder, don't we? But there's other bits. You know, this bad relationship with the healthcare team. You know, they've been told off so many times. You've got to do this. You've got to do that. You must do that. Hopefully that's changing. But there's a lot of historical stuff that people still get that. We've got a young girl who A1C of 120, and her GP told her she was the worst diabetic he'd ever met. You know, where'd you start? How'd you get out of that? And the big one is this weight loss at diagnosis. We all see that, don't we? People lose a huge amount of weight. They get started on insulin, and the insulin causes the weight gain. And that's our narrative. We've got to change that. Okay. No, it doesn't. Insulin restores your healthy body. It's different. It's a different thing. And we've got to change the way we talk about it and the way we, and warn people that it's going to happen. You're not gaining weight, you're restoring your natural body. You're retrieving your nutrition, etc. Okay, and why are they difficult to treat? Why is it so challenging for us? There's this marvellous word, egosymptotic. So basically the disease, this brain, this eating disorder's brain makes you believe that what you're doing is part of what you want to do. You absolutely need to do this. This is your life now. This is what you do. This is who you are. So it fits with your goals and everything. So actually people don't know that they're poorly. People absolutely deny that they're poorly. They don't get it. And even in remission, they don't understand how poorly they were. We've had people who've had more than one admission to an eating disorder. I never knew I was that poorly. I never got it. Okay. They often can't imagine life without anorexia or without an eating disorder because that's all they've got. I mean, that's, there's often the sick day thing, so the family or embrace you. Someone looks after you when you're poorly, don't they? So if you're poorly, people are there and looking after you. So it becomes part of their life. The emotions that people feel are terrifying. They're embarrassed, they're ashamed, they're frightened. So it's difficult to go and ask for help because you just feel awful in yourself. And of course, what role does hyperglycemia and ketosis play in not making you think straight? It's a big old role. And why is it difficult to identify? I mean, we all know we've got people sitting in clinics with A1Cs of in the hundreds and such like. How do we know what's going on? How do we find out what it is, etc.? They are very secretive, and there's no typical presentation. We're going to go into this in a moment. And there's lots of mental ill health in diabetes, isn't there? From very diabetes specific with the burnout and distress, etc. But also, people live lives outside of their diabetes. So they may have anxiety and depression. They may have past trauma. They may have personality disorder, all the rest of it. And they're all intermingled. So sometimes it's difficult to pick them out. And we're not very good at that. We can do the diabetes distress bit, or we can pick it up. We might not know how to deal with it. But the mental health bit we're not very good at unless we're trained in it. And so we're scared to raise the question. We're scared to ask the questions. We're scared to open Pandora's box and then, what do I do now? And the conventional screening tools, we don't use them in diabetes anyway. I mean, there are some, but they're quite long and bulky to be used in a routine diabetes clinic, so it's very difficult to pick them up. So when we started our pilot, this is the data from about 24 people over Wessex. And these were the clinical presentations that we found. So a lot of people are young females, but there are males and there are people who've had it for many, many years who've never told anybody, so don't use age. Most people are of normal weight. And the reason for that is this pervasive fear of gaining weight. It's not necessarily wanting to be smaller or thinner or a different body shape. It's this fear of gaining weight, and that insulin is going to do that. So that's where the problem lies, so you don't take insulin. Most have a body image disturbance. A lot of people have these other behaviours, so they'll exercise, or they'll purge, or they'll vomit. Some people have binge eating, and it changes. So as you shut one thing down, something else appears. So they'll start doing something else instead. You shut down the ability to keep the ketones high, and so they'll start exercising or something like that. A1C is an interesting one. Look, range 46 to 145. How can you have an A1C of 46 if you're not taking your insulin? Because you don't eat any carbs either. So some people have developed different ways of doing it, and we'll go into that in a moment. I've put known comorbid mental health diagnosis because a lot of these people just haven't been assessed. So we've got a psychiatrist on our team, she'll assess everybody, and that's when often these other things come out as well. And we'll go on to diabetes distress. So these are the phenotypes. So over time, this is what we've worked out is what the patterns look like, and it does matter because we manage them differently. So for some people, they will restrict their food. That's the big thing, is restricting carbohydrate. Because if you restrict the carbohydrate, you don't need to take insulin. But remember, this is irrational, so this is not talking low carb or anything like that. This is to the point where people can't take their 10 to 15 grams of carbohydrate when they're going hypo. So people have these recurrent, severe hypoglycemic episodes, and they'll beg you to have glucagon instead of having to take carbohydrate and things. It's a very severe form. So they tend to have the lower A1C. They're less common, but we certainly see people. Insulin restriction is the commonest one, and they tend to have a very, very high HbA1c, and they have this phenomenal ability to run ketones. So they can be running quite comfortably anywhere between sort of 3, 5, 7 in the community, and they come into clinic and you measure it and the ketones are 7, and you're like, woo, complete panic. That's what they do all the time, and they've compensated. So actually they're coping with that. And they've learned to take these tiny doses of insulin. When they get to the point where they're feeling a bit sick, I'll have a unit or two just to keep them safe, and they'll manage to tolerate that. And we use admission to hospital as a marker of how things are going. And actually you can't do that because people are so skilled at doing this that they stay out of hospital. They do not want to come into hospital because you're going to give them insulin through a sliding scale. So they don't want to come into hospital. So they run this tightrope. It's remarkable. And then there's the binge purge group, and again, as I say, people can move between the two. And then they may have the additional features as well. Okay, so when we started, nobody knew what it was. We didn't have a diagnosis. We didn't have a definition. It was just something that everyone sort of slightly recognised. It was slightly on the periphery. We didn't really know. So Dr. Figueiredo, who's our psychiatrist, spent a lot of time looking at all the people that had been through our programme and came up with what is our working diagnosis. And this is what the Royal College of Psychiatry are using in the Mead document at the moment. So it's people with type 1, so we're only dealing with type 1. I mean, there's a whole host of other issues with type 2, aren't there? But we're not dealing with that at the moment. So there's this disturbance in the way that one's body weight or shape is experienced, and this intense fear of gaining weight or becoming overweight. There's this recurrent, inappropriate, direct or indirect restriction of insulin, and the indirect is because they've restricted their carbohydrate. So the direct restriction, just not taking what's recommended, what's sensible, but the indirect is because of the not eating carbs. And then there's this thing about, people could be low carb and therefore not having a lot of insulin. And actually that's a lifestyle for some people, and that's fine. It's when it causes harm. And this is the difference between disordered eating and a proper eating disorder, is when it causes harm, when it's causing problems. And it could be harm to health. It could be the significant psychological harm or impairment in areas of functioning. So people can't work. People have no relationships, schools failing, universities failing, etc. So this is our working diagnosis. So what can you do if you're suspicious? So for a few years now, we've been using a pre-clinic questionnaire. We started it really because we wanted to pick up DDS scores, diabetes distress scores, and hypoglycemia scores and things like that. So we started this questionnaire, and then when we started the pilot, we thought, well, we'll add in a few other questions and just see if we can use them as triggers. Oh, hang on, it's not come up on the slide. There it is. So we added these one in. So I'm really unhappy with my body image. Again, it's not just, oh, I wish I was a size smaller or whatever it is. I wish my hair wouldn't go grey and things. It's proper distress, and I'm constantly worried about my weight. So we added these in, and then we added them up, and we looked at the diabetes distress scores. And what we found is that if you look at the top left, you can see there's a massive difference in the people who want to talk about their weight and body image as opposed to people who don't have an eating disorder. And when you look at the DDS scores, they're huge. They're really, really, everybody scored over 6. The majority of people scored 10 to 12. So they always score very, very highly on the DDS score. And if you put the two together, then you can see there's a massive difference. So people without TIDE, if you add up the DDS and whether they've ticked one or two of the boxes, 4.86 if they don't have TIDE, but 12 if they do. So it's a good place to open a conversation. It's not a screening tool, it's not recognised, it's just something we've done, but it gives you a start to a conversation. Okay? So suppose someone comes in and they've got a score of 12 and they've got an HbA1c of 117. What sort of things are you going to think about? Okay, I'm not going to make you put your hands up or anything, but what's going to work? Are you going to warn them of the long-term consequences? If you don't sort this out, you're going to go blind and your legs are going to fall off. You're going to recommend they wait 2 years for your next structured education course, or do Bertie Online, of course. Are you going to recommend a low-carb diet? Because that will help get your sugars down. Are you going to fiddle with their insulin, or are you going to do something else? And if you're going to do something else, what are you going to do? Okay? Don't warn people of the long-term... People with diabetes know about the long-term consequences of diabetes. And if they're frightened, if you frighten them, the frightened brain does not work. So it'll go into panic mode, and it won't be able to cope even more than it can't cope already. Okay? Structured education, brilliant, love it. These guys are struggling. They cannot cope with what's going on with their carbohydrate, with numbers, with everything. They don't need more numbers. Okay? So don't offer structured education. Low-carb diet, things are already in a pickle. This is one of my pet hates, this next one. Increase the basal or the bolus insulin. If someone's not taking 10 units, they're not going to take 12 either. And all you're going to do is bring them back next time and say, no, I'm not taking 18 now. Okay, don't fiddle around the edges. If someone's got an A1C in those sorts of numbers, it's not the insulin dose, unless they've got some weird insulin-resistant syndrome or something. On the other one, number 5 I should have put on there, or number 6 I should have put on there, is bring them back next week when you're on holiday, and then it's someone else's problem. That's what you should do as a registrar when you're training. Okay. We've talked about this. So what are you going to do? Okay. You've got to build engagement. These guys have got to trust you. They've had a hideous relationship with healthcare professionals in the past. They've got a hideous relationship with themselves. You are asking them to tell you their deepest, darkest secrets. You are asking them to tell you what Derek, I've forgotten what I've called him, what Derek here is telling them. Okay, you're asking them about the shame and the loathing and the embarrassment. So they've got to trust you. They've absolutely got to trust you. And you've got to normalise with them what's weird in their life. Okay? You know they're not taking insulin. They know they're not taking insulin, but you play this game, don't you? And, I wonder if we could do this. I wonder if we can do that. So actually, we're normalising the abnormal. Okay, we're going to talk about some of the words and the phrases that we can use to look at it. We're going to assess risk, okay, because they're going to be, even though they may be of normal weight, they are going to be nutritionally starved. They cannot get stuff into their cells, okay? So you're going to need to do some routine bloods. You're going to look at what's going on. So you'd certainly want to check what their liver's doing, what their kidneys are doing, what their bone marrow's doing, etc. You're going to check their psychological risk, because this is a form of self-harm. Okay, how dangerous is this? Are they at risk? And it's okay to ask people that. You know, what's your mood like? Have you ever thought of harming yourself? Do you think you're at risk at the moment? And you may not have access to all the services that you need, but there's always places like Samaritans, there's an emergency mental health team out there, you've got liaison psychiatry, etc. So just have some places at the back of your mind if someone does collapse in a heap, where are you going to go? Okay. The biggest thing you're going to do is pick up the phone and contact your local eating disorders team. Okay, they are lovely. All right. Now, one of the problems is they turn around and say this isn't an eating disorder. Okay. Fortunately, there is now this thing called the MEAD document, Medical Emergencies and Eating Disorders, which I'll give you the reference to. Annex 3 is now about type 1 diabetes and eating disorders. Okay, so you can go along to them and say, right, here you go. Yes, it is an eating disorder. This was published by the Royal College of Psychiatry. Okay, what you want to do is a joint assessment. Okay, because otherwise what happens is they'll see them in 3 months, you'll see them, and you'll write nice letters to each other. And that doesn't work. Okay, you've got to work together. So get them to come and see you. This is exactly how we started. I had a young lady that I had no idea what I was doing. I was messing around and not getting anywhere. And phoned the eating disorders consultant. She came and did a clinic with me, and actually a real success story. And if I get a chance, I'll go into that. You're going to simplify treatment. These people do not need carbohydrate counting. Okay, they're not carbohydrate counting. I'll give you that as a given. Okay. Simplify it. Okay, find out where they are. And this is where we have normalise the abnormal. So I would say things like, type 1 is really tough. It's shit. I do swear in clinic, I apologise. It's really hideous. It's horrible. It's horrible. Lots of people cannot do type 1 diabetes, and that's fine. I get that. Okay. What can you manage? Okay. How many times a week are you able to take your long-acting insulin? Let's accept that they're not taking it. Okay, if that's our starting point, how many times a week are you managing to take it? How many times a week are you managing to take your short-acting? Okay, and celebrate the positives. If people tell you that, it's positive. The fact that someone's come to clinic and they've had a blood test showing that they've got an A1C of 127, there is something in there somewhere under this eating disorder brain that's saying, please help me, please find out what's going on and help me. Okay, it's the ones that we don't see that I worry about, because heaven knows what's going on now. The ones that are coming to clinic are asking for your help. So try and get in there. Try and get in there. Ask these questions. Okay, celebrate the small wins. Set reasonable goals. Find out what their goals are, not yours. You know, we want time in range of 70%. What are their goals? And it may be that their goals are, I want to be able to go on a bus on my own. I want to have a friend. I want to go to work. I want to have a baby, whatever it is. And then see them again. Don't just send them out and, hope that they're going to come back, because they've had a bad relationship with healthcare professionals. They want to see the same person again. And they call it this therapeutic relationship. It's just the relationship's therapeutic. Okay, how do you open your conversation? So open. Okay, give them option to talk, and doesn't matter what they talk about. Okay, I can see you've scored really high on your diabetes distress score. Tell me about that. What's upsetting it? Tell me about your relationship with your diabetes. That's my favourite question in the whole world. Tell me about your relationship with your diabetes. Because if they go, it's shit, there's no point talking about carbohydrate counting. No point. Okay, start with the basics. Start with the absolute basics. Okay. Is there anything about your diabetes or your diabetes treatment that might be contributing to your concerns around your weight and body image? You don't have to ask them, does insulin cause weight gain? Are you worried that insulin causes weight gain? Get them to tell you. Because that's this thing that's going round and round in their head and terrifying them. When you voice it, it's like anything. When you voice something quietly, it just, oh, thank God I said that. It just feels easier. Okay? And you may need to ask it several times. This is one of my favourite things that someone told me once, that, when you come home from work and you've had a really horrible day, and everyone can sit on your face, and you're like, oh, and everyone goes, you're all right, I'm fine. Are you sure? I'm fine. And it takes 5 or 6 times of saying, I'm fine, and then eventually you go, do you know what? I hate that guy I work with. He's a real, it takes 5 or 6 goes to just ask someone where they are, how they're doing, what's going on. But do it gently, okay? So you can open the really, really open questions. One of our dietitians who's got the most amazing language skills, she goes, I'm wondering what that feels like. I'm wondering where things are getting tricky for you. I'm wondering, and you let them wonder with you. Okay, just engage with them. What do you think it might feel like if we? What do you think might happen if we? And just you know, rather than, why don't you take 2 units a day and see how we get on? Because it's what we do, it's what I do. Okay. So what are the key components of the interventions that we've come up with? So I work with an amazing team. I'm very, very lucky. There's me. I've got a consultant psychiatrist. I've got an amazing diabetes specialist nurse. In fact, I've got 2. We've got a psychologist. None of these are full-time, by the way. We've got an eating disorders therapist, and we've got a dietitian from the eating disorders unit. So I absolutely appreciate this is gold standard stuff. You know, I don't expect anyone else to have that at this point in time. But what we're doing is learning from each other of what we can do. And actually, we can all do things individually. I mean, my lovely colleague Nikki is here somewhere, and I'm sure if you catch her, she'll be able to tell you exactly the sort of thing that she can do on her own with just having had some of this experience. You don't need the whole team, but crikey, it helps. So you're going to engage. That's the first thing. We've got to engage in these people. And sometimes that takes months and months and months and months and months of phone calls and chasing. And how are you? How are things going? How's your dog? Diabetes doesn't matter for a little while. Get them to trust you. Okay? And then we do this formulation. So it's like a big circle where everything points in. What's causing what? What's contributing to what? What's driving what? What's stopping this? What's stopping that? Again, our psychologist usually does it, but you can contribute to it. You can start to say, well, this is doing this, and this bad experience has done that, and the concerns over their eyes or their feet or whatever is driving that, and this is driving that, and it's doing the whole thing. But it's got to be done with physical and mental health together. We've had people who've been in mental health units for their eating disorder, and they were given their pens and said, there you go, we get you eating, but here you go, you take your insulin. Go figure. And what we're doing is we're enhancing self-efficacy and confidence because they've lost all that. People are paralysed. They absolutely don't know what to do. I mean, sensible, intelligent people who sit there and go, well, do I take 1 or 2 units? I can't go to 2, not unless someone tells me to go to 2. And they're absolutely paralysed. This thing is thriving on ketones and hypoglycemia, and it won't let you do anything. So we've got to restructure and grow the brain and shrink the eating disorders brain. And you've got So is this on? Yep. Sorry about that. Too demonstrative when I'm presenting. People have got to develop compassion for themselves. We've talked about the feelings that they've got. You know, they feel hideous, they hate themselves, they're ashamed, they're embarrassed. You've got to allow people to accept that actually this is real, this is where we are. We're walking alongside, we're with you on this. We know it's horrible, but we're with you. And it takes a lot of time, so don't expect miracles. It takes 2 to 3 years to make big changes. So you're doing this slowly, and what you're doing is sitting on your own hands because you have this writing reflex. I'm a clinician, I want to make this better. I'm going to make this better. I'm going to find that one sentence that makes them go away and start taking their insulin. You're not. So you've got to control that writing reflex that's going to make it better. You've got to identify what they want, not what you want, what they want. Because you've got to come back to that time and time and time again. How do we work towards your goals? You wanted to do this by Christmas. What do we do next to get there? What's the next thing we can do to get there? Okay. You're going to identify crisis management. Plenty of people say, if I'd got sick, I wouldn't have called you. We've called ambulances on people several times just because we can't get hold of them when we're just scared about them. Sometimes we do supervised administration of insulin, so we'll get them to come up to the unit every morning sometimes for a couple of weeks at a time, just to get some insulin in, because this is thriving on hyperglycemia and ketones. So if we can shrink that down, they can start to think a bit better, and it avoids admission. And we do modified sick day rules. All our protocols and policies and everything are on the document that we'll give you. So if you do ever want it, it's there. So our modified sick day rules: 2 units of insulin for ketones of whatever level. It doesn't matter, because they're not going to take any more than that anyway. If you can get them to trust you to take 2 units, they take 2 units. And we do it, we phone them and they do another 2 units an hour later and another 2 units an hour later. Okay, so focusing on near normal goals, forget it. Just get something going. Small incremental steps that are attainable. You're going to have to learn to tolerate the high glucose and ketones, because they're already tolerating it. We don't like it, it's horrible. And you're gradually increasing the amount of insulin. Okay. Refeeding, it's a tricky one. In eating disorders, they're terrified of refeeding. And we were as well, so we started looking at it. Interestingly, we don't see it. The only times we've seen it are people who are vomiting as well, and they get very low potassium levels. And we think the reason is that refeeding is driven by insulin. So people who've been starved and you suddenly start feeding them, their pancreas wakes up and goes, "Oh, hurrah," and it chucks everything into the cells. We're giving so little insulin that we're just not seeing it. We still check for it and we'll give the vitamins and everything, but we're not seeing it. And a gradual move towards normalised eating. Most people, takes a long time to get back onto carb counting. A few do, but most people stay on fixed doses with some adjustments for high levels. Technology, if I have time, we'll come on to that and whether it's useful. The risks, so physical risks, obviously we've talked about some of these. We see a lot of this feeling very hypo at high levels, feel awful at blood sugars of 12, etc. So you have adapted carbohydrate intake for that, so 5 grams, 1 jelly baby, rather than the full dose, just to accept them. And we worry about the drop in glucose. We were just talking about that, about how quick is it, do you drop it? We drop it very, very slowly, mainly because they won't take insulin, so actually you can't drop it quickly. But you do get significant eye changes that we've seen, particularly in the, with the vision. But we have had at least one case of they were almost like malignant cataracts. It was remarkable. As we dropped the sugars, these cataracts just appeared. And we've talked about the mental health risks as well. So, have we done any good by putting all this work in? So, the slide on the left is an absolute classic picture of someone with Tide. Okay, so they're wearing their Libre, but it's undetectable. Sugar's just off the scale. I mean, that's absolute classic that we see. And then the one on the left, on the right, is someone who'd been in our eating disorders unit, and these are about 3 weeks apart, something like that. So you can make changes, but that took an inpatient stay. So, when we did this pilot initially, there was us and a group from the London, and we had an independent evaluation done, looking at outcomes over a year. In retrospect, it should have been over longer than that, but that's all we knew at the time. But you can see, if you look along the top line there, the total admissions for DKA, and you can see people getting in a mess. Things are getting worse and worse and worse and worse and worse. And then within the first year of seeing the service, things did improve. Interestingly, for some people, actually it got worse when they first started seeing us. It's almost like you open the floodgates and things go horribly wrong. We did get a nice reduction in HbA1c, so around 1.3-ish, and the people who had the higher A1cs at the start, 200 was our best that we had, can come down quite nicely to 2.5, and that's over a year. So actually, over a longer period of time, you do see changes. There's still a big discussions whether you get cure, remission, whatever you want to call it, and I don't know how to define it because I don't think people ever truly get over this. The thoughts and feelings and behaviours are still there. They just learn to deal with it better. Okay. This is the most important one. These are the patient-reported outcome measures, and you can see we measured loads and things. These poor people who were really poorly, we just bombarded them with paperwork and filled this form in. So these are some of the scores that we use. So the DEPSAR is the eating disorders, there's the quality of life, there's the paid scores, there's general anxiety, and the work and social scale is the one at the bottom that really matters. That's about getting people back into work, getting their life back. Okay, you don't need to look at the numbers, but basically they were all off the scale at the beginning and they all were coming into range at the end. So actually you can make an improvement by working with these people. So these are now the resources that we do have available. So there's some really nice podcasts that one of our a lady who's doing a PhD with us on this subject has developed. Everything we've learned is written on this guide to the risk assessment, and the college report is the Mead document. So it used to be called the Marzipan document, which was the big thing for eating disorders and anorexia, management of anorexia. They then renamed it as medical emergencies in eating disorders, and we were asked to write a section on type 1. So all our policies and procedures and everything were on there, including inpatient management, which we're about to write. We did have a peer support group, but that's on hold at the moment because of funding. And then Beat Eating Disorders, they're a fantastic resource, and we do a lot of training with them, so they're very much up to speed now. Because, of course, you worry that you send someone to a charity or support for an eating disorder, but they don't understand diabetes, and then you're just defeating the object. But these guys have done a lot of work now, so if you've got someone you think, I don't know what to do, I'm in transit, refer them to Beat. It's a brilliant resource. As is the podcast, actually. We're just doing some education resources as well. We're just in the process of writing those at the moment, both for inpatient and outpatient management for healthcare professionals and for patients. But they'll be a little while yet, but they're on the way. I know it's very short notice, but there is a conference next week in Southampton. It's the 5th one that we've run on this exact subject. I can give you the details if you want them. And as a last thing, I hope you can read this. I just want to say thanks to you all for supporting me to get where I am now. Around this last year, I was sat on a bench feeling pretty unwell, carrying litres of water with me, constantly drinking and desperate for the loo. Planning my days only ever involved how much water I could take, if there was a shop nearby, if there was access to toilets, and could I get to a hospital if needed. I'm not sure there was room for anything else. I felt dreadful but would never admit it. Today I'm sat on the same bench, having eaten 2 meals and not desperate for a drink. I can concentrate on just being here with friends. I don't feel I'm about to collapse. I can't taste ketones. I'm not worried of being sick. My legs aren't painful or burning. I'm not worrying if I have enough ketones but not too much. I'm not trying to decide if my next journey needs to be to A&E or if I can make it through the next few hours. I'm not dreading night time when no one's around. I'm not scared to sleep, wondering if it'll be the final sleep. Thanks for all sticking by me, for not giving up on me. I'd given up so many times, but you helped me pull me through. Where's the one? It says, she says, I wasn't sure how I felt with hearing how poorly I was. This is someone who's had 2 admissions to an eating disorders unit. Didn't know she was poorly. Thank you.